Sorry about that. I hit a button there somehow. Anyway, so some of the other risk factors for cigarette smoking are asbestos, arsenic, so heavy metals, secondhand smoke, air pollution. I know when I was shadowing Radecki down in Adena in Chillicothe, there's some kind of like chemical plant that caused all sort of exposure to um, chromium and arsenic and some other stuff. And so all these people had, and beryllium, and they were getting like these terrible lung cancers as a result of it. So I don't know, crazy stuff. So, all right, so lung cancer. So the overall 1 year survival is poor. It's 44%, 5 years 17%. If you can catch it early at localized early stages, then the 5 year survival is going to be about 54%. However, more than half of these patients are going to present with advanced disease or distant disease at the time of diagnosis. The associated 1 year and 5 years are 26 and 4 years and 4% respectively when they present with distant disease. So lung cancer pathology, kind of like that of colorectal cancer, follows a kind of a timeline. You get proliferation of basal cells, the development of some atypical nuclei, you get stratification of these cells, then you get metaplasia, then you get carcinoma in situ, and then you get invasive cancer. The most common type is overwhelmingly going to be adenocarcinoma. You'll hear non-small cell lung cancer thrown around, which pretty much includes adeno, obviously, everything but small cell. Small cell is a form of neuroendocrine tumor, which we'll talk about in a little bit. So the majority of them are handled, all non-small cell lung cancers are handled very similarly. So adeno is the most common type. It accounts for about 45% of all lung cancers. 75% of these are found peripherally. I think if you remember the mnemonic, or at least the little phrase that squamous is central and small cell is central, so the S's are more centrally. Adeno is typically peripheral. These tend to metastasize earlier than squamous and more frequently to the central nervous system. Multifocal disease, usually not amenable to resection. Squamous cell occurs in about 30% of patients with lung cancer. 2/3 of these, again, are going to be centrally located, and it tends to metastasize later in its presentation. Small cell is a bad player. It's about 20% of all the lung cancers. They are about 80% centrally located. They are aggressive with a tendency to metastasize early to the mediastinal lymph nodes and to like bone marrow and other CNS structures. They are derived from neural crest cells. I think I've seen this in a test question. They are sheets or clusters of cells with dark nuclei and little cytoplasm. They would kind of look like a whole wheat oat or an oat grain, and so they're called oat cell cancer sometimes. And then again, these are generally pretty advanced at the time of diagnosis, and therefore usually resection isn't going to be possible, and so chemo is the mainstay of treatment. The overall 5 year survival is about 5%. If you do get fortunate enough to catch it early and without any evidence of metastatic disease, then they may be considered for a surgical resection with adjuvant chemo. The NCCN guidelines are attached in the other additional information. I think you should go over that for lung cancer as well. But lung cancer screening, I know Leslie is did a research project on this, and the National Lung Screening Trial was a multi-center study which evaluated low-dose CT scan with chest X-ray. They had about 53,000 people who were enrolled and randomized into the two arms, men and women. They were asymptomatic. They were ages 55 to 74 with at least a 30-pack year history, and they had to have either be current smokers or quit within the last 15 years. The CT for 3 years compared with chest X-ray had a reduced lung cancer specific mortality and all-cause mortality. The death rate was reduced by 20% in this population, and all-cause by 7%. So the United States Preventative Task Force Service recommends CT for current or former smokers age 55 to 74 with greater than a 30-pack year history of smoking. In the office or in the hospital, your physical exam should focus on palpation of the lymph node basins and any kind of effects of paraneoplastic syndromes that can be associated with lung cancers that may be evidence in their labs. Non-small cell lung cancer. These symptoms are usually going to be based on tumor growth within the lung, so they may get, bronchiectasis or infections or consolidation and recurrent pneumonia or shortness of breath, maybe hemoptysis, bleeding into the airways. And then obviously you may find the solitary pulmonary nodule. There's a lot of literature out there on which SPNs are considered concerning and which ones aren't. Um, and I think it's important to know, but again, this can be deemed as benign with the absence of pathologic features. So if it's entirely calcified and it's been radiologically stable on CT for at least 2 years, then you can say with almost certainty that this is benign and you don't need any further workup. If you have a suspicious pulmonary nodule, you need to obtain tissue, generally by the most non-invasive means feasible. So some of those are, you can do a bronchoscopy, you can do transthoracic needle biopsy, you can do navigational bronchoscopy. More invasive obviously would be a non-anatomic wedge or a sublobar resection. What's nice about this is it can provide the diagnosis as you send it for a frozen sample, and then you can do your definitive resection at the same time of the procedure if it comes back as a cancer. Obviously, if it's somewhere, more centrally located, it's not amenable to either the non-invasive means, and you can't do a wedge, then a formal lobectomy can be considered. You're never going to do a pneumonectomy for a undiagnosed mass. You have to have tissue prior to doing a pneumonectomy. You can sample pleural fluid if they have a effusion. Malignant pleural effusions carry a very poor prognosis. You can send off the fluid for cytopathology. Generally, a couple times, if you do it, it may not be positive, but by the third time, it's got about a 70 to 80% sensitivity. If they have palpable lymphadenopathy, you can sample this, either by needle or by resection. In terms of staging, again, it follows the T&M staging. Look at the NCCN for all of the nitty-gritty details. Obviously, the T stage is the tumor size. As it increases, survival decreases. I think that's fairly obvious. And again, you can assess this via chest X-ray or CT. Obviously, CT is going to give you a lot more detail on the tumor characteristics, what it's invading, if it is invading, etc. So in terms of the end stage, this is really important for lung cancer. So mediastinal lymph nodes are present in about 26 to 32% of patients at the time of diagnosis. It's assessed initially with a CT of the chest. If you have any node that's greater than a centimeter on the axial imaging, that's highly suspicious for N2 or N3 disease, and you need to examine that further. Lymph nodes in the mediastinum can be biopsied via endobronchial ultrasound, cervical mediastinoscopy, endoscopic ultrasound again, or via the esophagus or VATS procedure. CT is about 57 to 70% sensitive for mediastinal lymph nodes for a non-small cell lung cancer and has a positive predictive value of about 56%. PET scan also does play a role in cancer staging, and it can be good to evaluate for kind of known or occult mets. Okay, so this is another area that I think can be somewhat confusing for residents, and it's something that we're exposed to, and if you don't really kind of understand what you're doing, it is confusing. So when you're talking about lymph node sampling within the mediastinum or elsewhere, it depends which approach you're doing to which nodes you can sample. So if you're going to do a cervical mediastinoscopy, so that's your kind of the one where you make your incision there just above the sternal notch in the neck, you kind of dissect down just under the manubrium, and then you put your scope in, and you are looking for nodes in there, and you can see major vessels that you're going to cross anterior to where you are, mainly the innominate artery. So anyway, you can get the lymph node stations 2, 4, and 7. The separator of the 2 and 4 is going to be the azygos vein, and then the 7 is a subcarinal. So more proximal on the trachea is going to be station 2, and then more distal is going to be station 4. And that will actually be kind of pre- or paratracheal nodes for all the way down distal from the azygos to the level of the carina. The Chamberlain procedure is a left mini kind of thoracotomy, if you will. It gets you access to the aortopulmonary window, which is where nodes 5 and 6 are located. And then a VATS procedure can get you access to, on the left, aortopulmonary window, 5 and 6, subcarinal, paraesophageal, and periaortic nodes. These nodal basins are important, and it's going to be required for sampling during your surgery. If you have a right-sided lung cancer, you need to sample stations 2, 4, 7, 8, and 9. and then stations 4, 5, 6, 7, 8, and 9 for left-sided cancers. The N1 nodes are those that are within the lung or the hilum, and then N2 nodes are mediastinal, and N3 nodes are as well, or supraclavicular as N3 nodes as well. So here you can kind of get the breakdown for the T size. You know, you can see there's a lot of detail in this, and I don't think it's super important to really get down into the nitty-gritty details, but the difference between like a T1B and a T2 tumor may determine whether or not you're going to be able to do upfront surgery versus maybe some neoadjuvant therapies. And then the evidence of nodal disease, where it is, kind of may determine also some treatment modality as well. You can see N2 disease is going to be metastasis in the ipsilateral, mediastinal, and or subcarinal lymph nodes on the same side. If you get nodes to the other side, that's going to be contralateral mediastinal or hilar nodes. That's going to be N3 disease. And then also supraclavicular nodes are going to be considered N3 disease, and metastasis is either obvious, it's, you know, distant mets. So the American Joint Committee on Cancer, the 7th edition TNM staging here, you can see 5-year survival based on stage, kind of that stage 1, 1A, 1B, where you kind of jump from T1B in size to T2A. You're going to start getting your pretty significant drop in your survival. And then as you get a little bit more advanced, any kind of N1 disease, which again, N1 is going to be considered mets in the ipsilateral, parabronchial, ipsilateral hilar lymph nodes, and intrapulmonary nodes, including involvement by direct extension. So same-sided nodes, N1 disease in the mediastinum, those are going to give you a pretty poor, fairly poor prognosis. You get a pretty quick drop-off from early disease without nodal involvement, 73% based on pathological staging, 5-year survival, drop down to about, you know, half that with evidence of N1 disease. N2 disease and any N3 disease, you're looking at pretty dismal 5-year survival rates. So again, stage 1, stage 2. So stage 1A and B, again, that's going to be kind of your differential between your size of your tumor, and then stage 2, you're going to get into your size plus or minus some N1 nodes. So if you have stage 1 and 2, you can get some adjuvant chemo after early resection based on nodals status, or you may just get your surgery, and if the nodes are negative, then that's all you need, and it can be curative. But adjuvant chemo for stage 1 and 2 has been seen to increase survival by about 5%. Stage 3 and 2 and stage 3B and stage 4, resection alone is rarely performed as the disease is too far progressed. Neoadjuvant may play a role in therapy in some of the stage 3A tumors and also in Pancoast tumors. Remember, Pancoast tumors, for those of you who are lucky enough to have Dr. Abney on your mock orals this year, these are tumors in the apex of the lung that generally invade into the sympathetic chain. You can get the classic Horner syndrome, which is meiosis, anhidrosis, and ptosis. So that classic triad could tip you off. Those patients need some neoadjuvant therapy and possible resection as well. Metastatic disease, it's incurable for the most part. Maybe rarely do they have some cure, but it pretty much portends a death sentence. There are some combination of chemoradiation that can prolong survival. They've looked at some epidermal growth factors as well as some programmed cell death 1 and programmed death ligand 1. There are some targeted therapies towards these that have seen some significant improvement in progression-free survival. Okay, so that's kind of lung cancer. Hopefully that's helpful summary of that. They talk a little bit about some of the other anatomical structures within the thoracic cavity and disorders involving them. So the trachea, so you got anterior, you have your cartilaginous rings, the posterior portion is membranous, your carina is going to be at the level of T4, normal diameter is about 2 centimeters. 2 centimeters you can tolerate up to about half of that being narrowed. If you get the diameter of about 5 to 6 millimeters, then you're only going to have about a 30% expiratory flow rate. Some of the primary tracheal neoplasms are going to be primarily squamous cell cancer, and about 2/3 in adenoid cystic carcinoma in the others. A third of these will have extensive local spread or metastasis at initial presentation. You can resect these patients with excellent results, and you just need to make sure you get negative margins, as that's important. And then if you have tracheal involvement from esophageal or lung cancer, that's stage 4 disease, and usually they just need palliation. You can provide tracheal stents, which can often work for that. Trauma. Again, this is covered in more detail in Dr. Chambers' lecture on neck injuries and aerodigestive trauma. So refer to that for full details. You can make this diagnosis by either direct inspection when you're in the operating room or by bronchoscopy. You're going to repair these primarily via a cervical incision for the upper half of the trachea, and then you're going to need a posterior lateral right thoracotomy for any kind of proximal left mainstem or carinal injuries. The maximum amount of trachea that can be safely resected is probably about 5 to 6 centimeters. There may be some variation in that, but again, you're going to be significantly limiting the flexibility of the neck and without undue tension if you start resecting any more than that. Tracheonominate fistula, this is an interesting this is an interesting kind of complication that's terrifying, and I think it's important to have at least a vague understanding of the steps in which to manage this if you were to ever see it, as it's probably not going to be infrequent that it's someone on call at night who has to deal with this, Harold bleed, that unstable patient that has concern for tracheonominate fistula. So I texted something out to the group earlier, but there's also a link that I attached that has a really nice detailed explanation of what to do, how to manage it. So refer to that for full details. Pulmonary mets, so from non-lung cancers, usually from soft tissue sarcomas. These tend to metastasize to the lung and can be resected safely and actually increase the survival rate. So it can improve long-term survival rates in 40% of patients, and you can actually do a resection of multiple recurrences of isolated pulmonary metastasis with good results. Some other miscellaneous tumors, so carcinoid tumors. So these arise from the Kolchitsky cells. They stain positive for silver, but also for chromogranin, which is why we get chromogranin A's on our pancreatic masses that we don't know what they are necessarily, or liver masses, etc., to see if they are carcinoid tumors. So you have typical and atypical carcinoids. Atypical is going to be your more malignant version. These are going to be your large cell, undifferentiated, and your small cell carcinomas. Carcinoid syndromes, this is when you're going to get wheezing, flushing. You can see some right-sided heart failure, diarrhea. I always remembered flushing and flushing, so they get flushing of the face, flushing of the toilet, diarrhea. This is going to be extensive disease burden if they do have this, likely with metastasis. The treatment for carcinoid tumors is going to be surgical resection. It's the standard, and you need to get a good nodal sampling and then complete removal of the tumor and preserve as much lung as possible. Survival rate is pretty good at 85% at 5 years for your typical carcinoids, and then atypicals are usually not treated with surgery as they are generally too extensively spread at the time of diagnosis. Some other miscellaneous tumors, so your adenoid cystic carcinoma, this is a slow-growing malignancy involving the trachea. A third of these will be metastasized at the time of treatment, and then radiation may be palliative management as if the cancer is too far gone for resection. Some other miscellaneous tumors you can see here, there's a whole host of them. I don't really think it's important for us to know the nitty-gritty details on all of these. You can look this up on your own time. And benign tumors are rare. They account for about less than 1% of all lung tumors. One of the classic test questions is, you have a popcorn appearance mass on a chest x-ray, and that's going to be your hamartoma. And then very rarely will lymphoma be primarily in the lung. It's usually disseminated disease, non-Hodgkin's lymphoma. All right, thoracic outlet syndrome. Again, I covered this in good detail on that Grand Rounds PowerPoint that I've attached. So refer to that for the full details. You're going to be affecting your neurovascular structures with this. Your neurogenic thoracic outlet syndrome is going to be the most commonly affected one, but you can get involvement of the subclavian vein, which can be considered Paget-Schroeder's disease, or obstruction or narrowing of the subclavian artery. There's a few different anatomic regions in which these vessels and nerves pass between the thoracic inlet and towards the upper extremity. You've got your interscalene triangle, which will affect the artery and the nerve, the costoclavicular space, which will affect the vein, or your subcoracoid area, which can affect any of the artery, vein, or nerves. Obviously, your symptoms are going to be based on which structure is compressed. Most of the time, if it's neurogenic, which we're talking about here, this can be initially managed with non-operative physical therapy. This fails not infrequently and requires surgery. The success rate with surgery is going to be about 70% at 5 years. If they have any of these symptoms that are worsening, progressive symptoms, prolonged nerve conduction on EMGs, or narrowing or occlusion of the subclavian artery, these are going to be indications for surgery as well, period. My sister-in-law had, she's kind of like a bodybuilder, so repetitive motion of over the head, so weightlifting is one of the causes for this kind of spontaneous thrombosis of your subclavian vein, known as Paget-Schroeder's disease. This is usually treated with direct catheter thrombolytic, which they attempted with her. This did not improve it, and so she underwent first rib resection as well as then thrombectomy. So it's a kind of interesting disease. All right, the pleura. So pleural effusions, you can determine whether this is exudative or transudative based on, I think if you all remember, Light's criteria from step 1 or medical school or whatever it is when you learned that. And that's going to be based off of the pleural fluid comparison with the serum comparison. And again, just to reiterate what Light's criteria is, as it's not something in the forefront of our head, if you have an exudative effusion, you're going to have a pleural fluid protein to serum protein ratio greater than 0.5, or a pleural fluid lactate dehydrogenase to serum lactate dehydrogenase ratio greater than 0.6, or a pleural fluid LDH or lactate dehydrogenase 1.67 times the normal serum level or higher. You can also just look at it. If it looks like pus, it's exudative. Most of these are going to be transudative, right-sided heart failure, reactive pleural effusions, maybe even a malignant pleural effusion, depending on what the consistency is. So some of the normal circumstances, you get this undergoes by Starling's law. So net pressure moves the fluid from the parietal pleura into that pleural space. It's an incredible amount each day. 5 to 10 liters are produced and transgress over the space, but 99% of that is reabsorbed via the lymphatics in the parietal pleura. Malignant pleural effusions, like I mentioned earlier, so obtained after about 3 thoracentesis, you may get the diagnosis in about 70 to 80% of patients. If you do have a malignant pleural effusion, it's associated with a median survival of about 90 days. Now that's median, that's not an average. Some of the treatment for these, you can put in indwelling catheters, you can use pleurodesis, or maybe just repeat thoracentesis as needed for symptomology. Empyema is something you're going to deal with a lot on the thoracic surface. So this is when mucopurulent debris within the pleural space compresses the underlying lung parenchyma. You can have a chronic phase where it's organized and it can cause lung entrapment and capillary ingrowth, creating this like super thick rind where they can't get good expansion of their lung. You're not going to be able to just drain this with a chest tube as it's thick, loculated, and needs a surgery. It's most commonly due to gram-negative and anaerobic organisms at this time, and then obviously your treatment is going to depend on the extent of the disease. Complete and dependent drainage is required. Intrapleural TPA and DNase, we just tried this on a guy here recently. It didn't work after a few days of doing that, and so he needed surgical drainage. Bronchopleural fistulas following lobectomy or pneumonectomy can predispose patients to empyema, and then you can have a chronic empyema with a residual pleural space, and it may get this thing called an Eloiser flap. I think I didn't include a picture of the Eloiser flap. So the Eloiser flap, look up a picture on your own. It's pretty impressive. You just take a tongue of tissue. You kind of take the subcutaneous fat and reflect it off the chest wall, kind of resect a portion of some posterior lateral ribs in an area that's dependent enough that's going to drain some of this, and then you put this tongue of tissue back down kind of into that space, and you kind of tack it to the diaphragm, and then this allows for drainage, and this is usually packed with wet Kerlix gauze, and it takes about, it can take weeks to months for these things to close down, and then they have this kind of epithelialized hole in their back that's about probably the size of a racquetball, or maybe even a little bigger. But it's some impressive pictures if you look it up. Chylothorax. So this is when you have a drainage of chyle into your pleural space. Your chest tube may appear milky, and you can send the fluid for triglyceride levels to confirm the diagnosis. You can try and treat this with just drainage, fluid and nutritional replacement, make them NPO, give them TPN, give them medium chain triglyceride diet. You can try and go back into the chest and ligate the thoracic duct where it enters the diaphragm. This is approached via a right thoracotomy. Remember, it crosses over from right to left at the level of T5. And then at certain centers, and I think actually we're doing this now at Mount Carmel, you can do IR can try to embolize the thoracic duct by going in the toe or the foot, cannulating the lymphatics down there, and then traveling it all the way up. I've never seen it done, but it sounds interesting. All right, that's pretty much the end of it. The chapter does go on to talk about the mediastinum. I think go over my PowerPoint for the grand rounds. The keys to know for the mediastinum are just going to be probably the masses within the anterior mediastinum. So I think we all know the terrible T's. You've got your thymomas, teratomas, terrible lymphoma, and thyroid tumors that can extend down into the anterior mediastinum. So those are your 4 terrible T's. There's a huge host of other things that can, be found in these mediastinal spaces, from germ cell tumors, carcinomas, cysts, lymphoid hyperplasia, neurogenic tumors, etc., lymphomas. So a lot going on there, but I think if you can know the anterior mediastinal terrible T's and just how to approach those, you'll be probably enough information for you. I think that's the majority of the chapter. Thanks for putting through my voice for about an hour. There are 2 here since I messed up the recording halfway through. So good luck on ABSITE. Hopefully this is helpful, and